Welcome, everyone. It's my pleasure to introduce the next session, which is entitled Updates in Pediatric Kidney Transplant. Please feel free to ask your questions in the Q&A area at the bottom of your screen, and our presenter will either answer them during the conversation or we'll have them answered for you later and posted to our website, which is transplantfamilies.org. My name is Anne-Sarah Pabanga, and my daughter had a kidney and liver transplant nearly 18 years ago. I am a volunteer for Transplant Families and find that it's very important to educate those who are facing pediatric transplant. So I'm really happy to be here today, and I'm very happy to introduce Dr. Paul Grimm, who's a nephrologist from Stanford Children's Health. He is here to explain some of the latest innovations in pediatric kidney transplant. And then later on in the day, we hope that you will stay tuned for some special bonus content that we have from Leslie Wyers. She is the mother of 2 kidney transplant recipients, and she's currently the IROC, Improving Renal Outcomes Collaborative co-chair of the Community Engagement Work Group, the CEW, and she's going to be sharing some really important materials, so we hope that you will stay tuned for that information. Without further ado, Dr. Grimm, thank you.
Hello, good morning. My name is Paul Grimm. I'm a pediatric nephrologist, and I'm really delighted to be able to speak to all the members of the transplant family community. And I know there may be some older patients watching and many parents and extended family members. So, hello. So, this talk is a general talk on some of the latest advances in kidney care and transplantation. You know, when you're a parent of a child with a rare disease, you're always looking around for what's new, what's different. Is there something some other center is doing that I don't know about or my team doesn't know about? And so I just love this animation of these eyeballs looking in all sorts of directions. And that's basically what anybody of a family with a rare disease is doing most of the time. So I'm going to give you a bit of a smorgasbord of the changes in the last year or two in overall kidney care. And these are relevant if you have your own kidneys that are still working but are damaged or not working so good, or if you have a transplant. So one of the things which is really a game changer is a group of drugs called the SGLT2 inhibitors. And they go by the name flozins. There's canagliflozin, dapagliflozin, and empagliflozin. So we talk about flozins, and in fact, in the kidney community, people who love these drugs are called flozinators, and I'm a flozinator. Originally, these drugs were marketed to treat diabetes because they reduce the sugar reabsorption by the proximal tubule. So the filter in the kidney filters the blood and sugar comes out, and this part of the proximal tubule reabsorbs all that sugar to hold on to your body. And the drug blocks that, and so it makes you pee out sugar. It's not a great diabetic drug, but it turned out to everybody's surprise, it had all sorts of other effects all over the nephron and the kidney. And in fact, big, huge studies of multiple drugs of this class have shown the same thing. These drugs slow down the deterioration of kidney failure. So this is a big study where the people were on placebo or a flozin, and this was their estimated GFR, so the glomerular filtration rate, normal being above 90, kidney failure is sort of less than 20 or 15, right? So the blue was the placebo group, the people who got the sugar pills. The yellow is the Flozin group. So you see the GFR goes down a little bit right away, but then the slope changes. And so by 3 years out, the patients who were on the drug were doing better. So what it basically does is it takes the kidney and the leftover filters that are still working are working so hard that they're actually aging really quickly and they're burning out. And the drug somehow tells the filters, don't work quite so hard, take it a little bit easier, and they last a lot longer. And this has been shown in multiple studies. So let me take you on a tour of the kidneys. So this is the kidneys. They're deep, deep in the body against the backbone, well protected. And this is a magnified view. And then as you go into one kidney and you get a microscopic section of the filters, you're going deeper into the kidney, and there is the glomerulus. This is the filter part, which filters the blood. And then the tubules, all these guys here, reabsorb the stuff that the body needs or doesn't want to get rid of. And if you go deeper, The cell that controls the filter is this podocyte. And this image is a healthy podocyte. And the different podocytes send out all these finger-like projections, and they interdigitate with the fingers of the next podocyte. And so they talk to each other and they control the glomerular filtration. And in someone who has CKD, the podocytes are damaged and those finger-like projections are gone. Well, it turns out that the flozins help these glomeruli, the damaged podocytes, bring back the fingers and bring back their structure and reduce inflammation and scarring biomarkers. And this is all something that was totally unexpected. In addition to the kidney, there's evidence that the flozins reduce inflammation, which is generated by liver cells and other cells of your immune system and intestinal cells. And these are some of the different genes. You don't need to memorize all of these, but some of the different genes that are involved in various parts of regulation of the body and controlling inflammation, which are affected by the flozins. But what's really surprising is how the flozins are protective of heart disease. So, in the patients who are on flozins, the risk of progressing to kidney disease or death from cardiovascular causes was dropped in the flozin group compared to the placebo group. Now, this is adults, but there's clearly evidence that in heart failure and heart disease, the flozins do something directly to the heart, out of keeping to whatever diabetic control they provide. Okay, moving on from the flozins, iron. We think of iron as something that's important to make blood, and that's the end of it. And so if your iron levels are low, as long as you're not too anemic, big deal. CKD patients, people with kidney disease, hate taking iron. The pills have a bad taste. They might make you burp sort of metallic flavor, gives people constipation or indigestion. We know it's a battle. What we found out, though, is the iron in your body, in addition to controlling your blood cells, has a direct effect on the quality of your heart. And what was shown in this big study of adults who had pre-dialysis chronic kidney disease is the people who had the more likely to develop a cardiovascular event were the ones that had the lowest saturation. So the lowest saturation, less than 20%, here is the blue line. So this is the people who were protected from a heart event. And by the follow-up time, something like 80% of people who had the lowest iron saturation had a heart event. And the best outcome was in this yellow line. Much more people protected from a heart event. They had an iron saturation of 40%. Now, in clinical practice, we say as long as you're over 20, you're good. But lots of people live at 5 or 10% and don't want to take their iron supplements. But this data suggests it's more than just anemia. And so in CKD, a big practice change is we're doing more and more iron infusions. So if a person is unable to tolerate the iron that is needed by mouth to get your iron stores adequate to protect from anemia and to protect from other issues, we'll bring the patient into an infusion center and give them a big dose of an IV iron preparation. And they're very safe now. And that might be good to last you for 3 to 6 months sometimes, um, to improve your iron stores, even if you're not anemic. So this is a big game changer. Everybody's heard about the GLP-1 analogs, the weight loss drugs that are in the news, and you're wondering why Donald Trump looks so skinny and all the news media and talking heads and movie stars, they all have chiseled jaws and they're losing weight. It's these drugs, the Wegovys, the Ozempics, and things like that. So people are wondering, do those drugs help with kidney disease or heart failure as well? And there are big studies that are looking at using these drugs and comparing them head to head, the GLP-1s, which are the Wegovys of the world, versus the flozins. And in this very large study, what they showed was people on flozins, as opposed to the GLP-1s, had a more marked effect on preventing hospitalization for heart failure and progression of kidney disease. So for treating diabetes or treating overweight, the flozins and the GLP-1 drugs are great. But it looks like the flozins are still ahead at protecting those kidneys and protecting your heart from heart failure. Moving away from pre-kidney loss, let's talk about some of the things that are in the news. And one is the wearable artificial kidney. Over the years, they've been working on trying to work out the bugs of this device. And right now, the latest version is only 3 pounds. It's rechargeable batteries, and you wear it and it cleans your blood. So you don't need to go in for dialysis every day. They're still having issues with blood clotting and vascular access, but they've come a long way. And so at a recent conference, they showed this picture of this uh, gentleman having a shower wearing his artificial kidney. I'm so glad you don't have to plug that into the wall socket. Otherwise, it would have been a shocking experience. But they've clearly made progress. And maybe one day we won't need to come in for dialysis 3 days a week or do peritoneal at home if they can keep working on this, which is really cool. Kidneys grown in the lab from organoids. There's a lot of labs all over the world, and at Stanford, I have two colleagues who are really working on this project with the idea that you take a kidney sample and you grow that tiny piece of kidney in the lab. And using different technologies and stuff, you can actually get kidney-like structures would have glomeruli and tubules. And this is an example of something that's been growing and getting bigger and bigger, and you can see the tubules reaching out. And this has been in the lab for 2.5 months. And then this staining is showing that there's different kinds of cells that are present in these kidneyoids. Now, okay, obviously you can't transplant something like this, but people are looking at transplanting small kidneyoids into lab animals to see if they'll actually grow into bigger kidneys. And also, people are looking at this as a source of cells for three-dimensional printing. You may not be able to grow kidneys big enough to actually transplant in the lab, but maybe you can use them in a printer. So, you've seen 3D printers making machines and plastic and toys and stuff like that. Well, this is a 3D printer to make living cells turn into a structure. And this is an Israeli study. So this is the 3D printer and the needle, and it's making a heart. And that sucker beats. So this is just mouse heart size, not human heart size. But they are doing wonderful things with three-dimensional printing and with growing cells in the lab to use in tissue. And this is a human who had a damaged ear, who had their ear restored. It's not perfect, but it's cosmetically adequate when looking from far away. And this was three-dimensionally printed using their own cells in the lab. And maybe one day we'll be getting kidneys that way. So there's a separate talk on genetically engineered pigs. So I'm only going to mention a couple slides because this is just so fascinating. I couldn't not talk about it. So pigs have been around with humans for hundreds of thousands of years. But if you take a kidney from a pig and you transplant it into a human, it's immediately destroyed because there are too many differences between the immune system of the pig and the human. And so the body instantly sees that the pig kidney is strange or foreign. So what people have been doing is genetically engineering these pigs to change the specific genes in the pigs and also get rid of any viruses because pigs have all sorts of viruses in their genes, and some of them can jump out and turn into a virus which could potentially affect humans. And that's where we get the flu every year because a new flu strain develops in pigs in Southeast Asia, and then they spread around the world. And every year we have new flu strains. So the latest pig has 69 genes that have been adjusted, either silenced or increased or altered. Originally, kidneys were placed into human brain dead donors, and so they got special permission from the next of kin. They would keep these brain dead donors alive, and they'd put the kidney in and see how long the kidney would function. And these kidneys were lasting for weeks in this brain dead donor. An earlier version of a genetically engineered heart from the pig was transplanted into two high-risk patients recently, and they made the news. But what was so cool was in the mid-March of this year, a 69 gene edited kidney was transplanted into a 62-year-old man who otherwise would not have qualified for a kidney transplant. He had had a kidney transplant, it was failing, and he didn't qualify because of various reasons. So he bravely offered to be the first person in the world to get a kidney transplant from a pig. eGenesis is the company, and they had 3 edits to remove surface sugars that cause instant rejection, 7 edits to add human proteins that prevent rejection, 59 edits to remove viruses. And these kidneys have been transplanted to monkeys, which are very close to humans, and those kidneys have been lasting for months to years. And this is the gentleman here surrounded by his team on the day he was discharged from hospital about 2 weeks ago. And he's hopefully going strong and will go for a long time. Fingers crossed. This is very much research. He's on a bunch of special drugs, more than most people. We don't know how long this kidney will last. And clearly, if you have a child or a young person, you want the kidney to come with a money back guarantee for 20 years. So obviously, these pigs' kidneys are not ready for your kids, but maybe one day. All right, changing the subject once again. People always talk about the inequity of the transplant system. And back in the 1990s and 2000s, children who had African heritage waited longer for a kidney transplant than children of white heritage. But as time has gone on and we've adjusted our allocation models, that wait time is narrowed. So this is a graphic that shows the transplants per 100 patient years for children waiting for kidney transplant by race and ethnicity. And the X's are white kids and the triangles are black kids. And you can see, although there's variation from year to year, on average, most people wait about the same length of time, except some of the others. And there are very few patients that are actually in the other group. So this is sort of a it's sort of a false number, but everybody's pretty much locked in. There's still a big difference in living donation, but at least in deceased donation, people are waiting about the same time in childhood. But living donation is the issue. So right now, when someone comes into my clinic and I'm teaching the family about needing a kidney transplant, we have to explain that if you get your typical kidney from a deceased donor, they last on average in the United States, based on our most recent data, 11 and a half years. So that means if your 5-year-old gets a kidney transplant, on average, by the time that kid is 16 or 17, he or she's going to need another kidney transplant. And then another one 10 years later, and another one, and another one. Whereas if you get a kidney from a living donor, that's 19 years they last on average, and some last way longer. So there's a huge difference. And that's not narrowing. In fact, that's getting bigger. Back in the late 1990s, the difference between living donors and deceased donors was about 4 years. And then in the early 2000s, jumped to 5. And in the most recent cohort, it's 7.5 years. So living donors provide a tremendous benefit. But the problem is kids get a lot less living donors than they used to. When I started out doing this a very long time ago in the 1980s, kids got more living donors than deceased donors, and that has just plummeted. So this graphic shows going back to 1990, within the first year after being put on the list, 35% of kids used to get a living donor from their parents. And that's dropped to less than 20%, so nearly half as many living donors from parents. Now, other sources of living donors, like other relatives, unrelated, half siblings or siblings, they haven't changed. It's the parents. Why? Two reasons. One is parental health. As we have more diabetes, more obesity, which is unhealthy weight, that is reducing the success of people being prepared and approved for living donation. And the other big factor is economic barriers. In the United States today, 50% of children are born to a single parent household. And if you have a single parent and that parent wants to donate, who's going to look after the rest of the kids? Who's going to go to work in the fields or work in your job to pay the bills so you have a house to come back to and you've got health insurance to cover your expenses and food on the table? So if you're a single parent, there are tremendous financial barriers to being a successful living donor. And so those two things are conspiring against living donation. But there are many patients who could get a living donor who don't. Oh, wrong slide. And this is continuing. So this is pediatric recipients up to 2022 in the United States. Blue is the number of deceased donors slowly going up every year. But the number of living donors from all sources, dropping, dropping, dropping. There was about 300 kids got a living donor per year in like 2011, 200 in 2022. So a third less in 10 years. We need to change this trajectory. We need to stamp out the idea that I'd like a living donor, but the kidney didn't work. Uncle Tom wanted to give a kidney, but it didn't work. Or Aunt Susie wanted to give a kidney, but it was the wrong blood group. We want to stamp that out. We can use those kidneys. For one thing, there's something called A swap. So say a mom wants to give her kidney to her son, but because of a blood group mismatch or something like that, she can't. And this guy here, the husband wants to give his kidney to his wife, but there's some barrier there. Yet it turns out mom can give her kidney to this guy's wife, and this guy can give his kidney to mom's son. Everybody wins. This is called a swap. This is a two-way swap, but you can do chains, and we have chains that are started by someone who's a good Samaritan, someone who is an altruistic donor who just wants to give a kidney to someone because they've had a good life and they want to give back. That can trigger a whole cascade of chains going on. And there are programs that have made the news by doing like a chain of 30 or 40 people long. But actually, we're getting away from these. Previously, these were all done the same day. Like people would be lined up in the OR, it'd be like on an episode of what is that? Seattle Grace. What are they? Not St. Elsewhere. Whatever that television show is that's been going on for like 15 seasons with Meredith. Um, they had all these people lined up. We really don't do that much anymore because we now have the National Kidney Registry. Now, when the National Kidney Registry was starting, I wasn't sure if this was going to be successful, but it is tremendously successful. The idea is that they have a voucher program. So, say you want to become a living donor, but you've been told you're not compatible with your intended recipient, or you're a poor match and you want a better match. Or say you know your child or your uncle or niece or whatever is going to need a kidney transplant in the next few years, and you're healthy now and you don't know in 3 or 4 years if you're going to be healthy because, maybe you climb mountains or something like that. You can donate now so that your intended recipient can get the kidney when they need it, or you can protect your family members. So the idea is you donate now to the registry, and someone gets your kidney now, and you get a voucher. And so when you need a kidney or your loved one needs a kidney, your transplant program contacts the NKR and says, I have a 4-year-old child or a 6-year-old child who has a voucher number so and so and so and so. They check. Let's look at the kidneys that are on offer now. And we go through the kidneys. Oh, this is the right blood group. This is the right size. This looks like a good one. This is from a young donor. We'll take that one. And then that person in Chicago or whatever goes to the OR, donates their kidney, gets their voucher into the program. That kidney flies to us at Stanford, and we implant the kidney, and everybody wins. This is a tremendous benefit. So if anybody wants to donate and has been told, oh, you're the wrong blood group, oh, you're a little bit too old, we can now get them to donate to the voucher program because someone will need that kidney. And then you can get a better kidney for your child. The NKR, as of last week, had facilitated 8,784 living donor kidney transplants. This is cool, and we're using this in our program. Transplant centers in general are under pressure to avoid risk. The reality is there are many organs that could be transplanted that are thrown in the trash if they're deceased or not taken if they're a living donor because surgeons and transplant programs need to meet super high standards. If your success results dip below a certain arbitrary number, insurance won't send patients your way. And all of a sudden, your program is much smaller or you have to let people go. Or worse, you may get an audit by the United Network for Organ Sharing, UNOS. We say going to UNOS jail. Nobody wants that. And so people are disincentivized to take kidneys which maybe have an 80% chance of working. Yet we know there are lots of people. There's almost 400,000 Americans on dialysis today. Only 100,000 are on the wait list. And that's because their doctors know most of those people will never get a kidney transplant because we only do 25,000 a year. So most people who are adults on dialysis will never get a kidney transplant. So they would jump at the chance to get a kidney that maybe had an 80% chance of success. I'll take that gamble. And so we need to be cognizant of this and recognize that that we need to start looking more closely at organs that we might have said no to before. And in my program, we are reassessing things that we used to say no to 20 years ago, like that older donor. In the fentanyl epidemic, which is horrible, there is a tiny silver lining, and that is there's a lot of young people who can be great organ donors. And so we've taken patients where they had been found with a needle in their arm. People with previously untreated TB, we can either treat the donor beforehand or we can treat the recipient for a few months afterwards. In people living in Central California, in Arizona, in New Mexico, in Nevada, cocci is a protozoa or a bug or something that there's more and more of because of climate change. If you had a donor that was cocci positive, we usually wouldn't take them. Now we are because we can treat the donor and we can treat the recipient. Toxoplasmosis, more Central America, East Coast, cats. Lots of people in Mexico and South America are positive for toxo. You can treat the donor or you can treat the recipient. So we're taking those. In fact, we've taken all of these for our children with very clear counseling and risk and benefit ratios, and the families buy in on this. They can get that really good kidney from that 20-year-old donor, and we'll treat that TB positivity in the child for a few months. Done. We haven't done hepatitis C yet, but we wouldn't rule it out because hepatitis C is curative. Okay, changing the subject to the last topic. And this is something very controversial in the post kidney transplant world. And many of you might have gotten involved with this because of advocacy biomarkers. So, biomarkers can be assays and tests of kidney tissue or heart tissue if you're a heart transplant or liver tissue if you're a liver transplant. Other tests are non invasive, like urine or blood. And what biomarkers do, they can be for diagnostic purposes, for treatment of rejection, prognostic purposes, how bad is the rejection, monitoring. You were treated for a rejection or you just got a kidney transplant. Let's do the biomarker test and see if you've got rejection or a surrogate endpoint for research. So there's lots of possibility for these biomarkers, but there's been some real issues recently. And the biggest and most well-known area is something called cell-free DNA. So there's a blood test that's offered by 3 different companies that you take a blood sample and it can tell what percentage of the DNA in the circulation belongs to your transplanted kidney. And it's a pretty cool test. And what they showed was, and there's a bunch of different studies, like in the DART study, what they showed was if you take a whole bunch of kidney transplant recipients, most of the people have less than 0.5% of the DNA in that blood sample being from the donor kidney. And very few were above 0.5%. So then they said, okay, say you have a blood test which shows that you have more than 0.5% donor-derived DNA. Well, your risk of getting donor-specific antibodies, DSA, which is a harbinger of a rejection, was worse. So these were people free of rejection and DSA. So if your cell-free DNA was less than 0.5%, you were very low likelihood to get the DSAs or rejection. If it was above 0.5%, you were more likely. That's cool. And then other studies started looking at, well, what's your cutoff? Like if you select a really tight cutoff of 0.2%, you're very sensitive for rejection, but most of the blood tests that say rejection are going to be false positives. If you change the cutoffs, the sensitivity goes down, but the specificity, the number of false positives, is way better. So there's a lot of controversy about where to draw the line. So then doctors and transplant programs started ordering these all the time in Medicare patients and private pay patients, and Medicare was going to go bankrupt. So they started looking at things. It turned out one blood test for the cell-free DNA was $2,800. The entire Medicare cost for an entire kidney biopsy is only $1,500. And some transplant programs were ordering these every month. Well, Medicare was going to go bankrupt. So they started looking at who should get a cell-free DNA test, and they looked at risk-benefit ratios, thresholds, and what they suggested was, from a pure cost basis, the only person that should get screened was someone who was young, who was expected to live a long time, and maybe once or twice in the first year. Anybody else should just get a kidney biopsy because it's way cheaper, more likely to diagnose the truth. And so then what they did was Medicare came out with these rules that said all of a sudden, put your foot on the brakes. They were not going to pay for these tests unless there were very specific circumstances, like you did the blood test instead of a kidney biopsy, or you did the blood test after you found that the creatinine went up and you were trying to see why the creatinine went up. You couldn't just do it month after month after month, which a lot of programs have started doing because Medicare was going to go bankrupt. Okay. So then there was another set of tests that were looking at gene expression in the blood. and one was called TrueGraph. That was $2,600 for one blood test. One was from called T-Rex, different group of people, and then one was the CTOT-08 study. So all these had a different blood test that looked at different genes to determine who's rejecting and who isn't. So then they started saying, we should get Medicare to pay for all this. And so there's been a lot of patient advocacy out there. One of the companies had something called Honor the Gift, and they had people marching on the Capitol. And then another group had was putting various articles into various local newspapers and things like that. And then another company also was having patients writing columns all about advocacy, trying to get Medicare to pay. So then another company said, maybe you should combine the blood gene expression test, the gene expression, and cell-free DNA. So they did that, and they said if you do both tests together, you can rule out rejection to 88% level. So they wanted to put this big study together, combining those two blood tests, do a bunch of patients, and they basically had to stop because Medicare said, in addition to only doing the cell-free DNA very specifically, you can't do these two tests together because we will pay for one or the other. Because together it was going to be like $5,000 a pop for each one of these blood tests. And so the company that was going to do this basically said, we're out of business. Okay. So blood tests are really controversial, very expensive. We wouldn't be having this discussion if they were the same cost as a blood count, $5 or $10. But when they're $5,000 a pop, it's not something that can be paid for on a regular basis. But if it was 50, then I would be doing these on my patients every month instead of a CBC. So there's some people that are looking at urine testing for rejection, and that's cool. That might be cheaper. The reality is if you're looking at this area and you got involved with this advocacy and these companies trying to make money, research is messy. Money funds research. There's no doubt about it. And the capitalist system is better than any other system because there's innovation, because people are hoping to get rich. But researchers and businesses, there's ego and there's hubris. Things always take longer than hoped. I remember in the 80s, I watched presentations on using pigs or other animals for organ transplant, and we're now 40 years later, and maybe it's going to happen. It was just around the corner back then. Things always take longer than hoped. Findings must be consistent and able to be replicated. There are a number of companies that put out blood tests that they said this is the gold standard to predict rejection. And when other people did the studies, they found it was rubbish, and all this money was wasted. So the scientific method continues to move, or actually lurch forward. We all learned that with COVID, right? Scientists say something 1 month, 3 months later, they say something different. But through open dialogue and continually reassessing outcomes and continually having the scientific method where you look at the outcomes and making the best guess, making predictions, and then seeing if they come true, that's the scientific method. Sooner or later, error and fraud is always revealed, and the truth is what stands the test of time and continued scientific challenges. So I hope I've told you a little bit about something that you were interested in. I didn't bore you with stuff that you weren't interested too much. And I'm hopefully going to be able to answer any questions you have. Thank you very much for listening.
Thanks, Dr. Grimm, for that wonderful presentation. So I'm Leslie Wyers. I am the co-chair of the IROC CEW, a lot of initials, but through our presentation, I will explain what all those initials mean. I am a parent of 2 children with kidney transplants due to a disease called nephronephrosis, which is a cystic kidney disease. My children were transplanted at the Children's Hospital of Philadelphia. My co-chair is Haley Figueroa, and she also has 2 children with kidney transplants. So together, that is a pretty high percentage of our small population. What is IROC? It is Improving Renal Outcomes Collaborative, which is a learning health network. It is dedicated to partner with patients who have kidney disease, most of which have transplants, and their caregivers, because what we want to do is to achieve health, longevity, and the quality of life equivalent to the general population. There are currently 44 IROC centers across the country, and 28 of those centers have a representative on the CEW. Our goal is to have every center represented, and in fact, have every parent or caregiver of a child with kidney disease be a part of the CEW. So the CEW, the Community Engagement Work Group, has 4 main priorities. The number one thing that we do is provide support. We support patients and families because we've gone through this journey. We're able to understand the acronyms of labs and TAC, and we're just there to hear each other and to support each other. Another thing that we do is we do education. We develop some educational materials that you're going to see on some later slides, and all of our educational materials and projects have come organically out of our own membership. The projects and resources we've developed, I'm very excited to show you, and are shared among our IROC centers. And we also have developed strategic partnerships. Because we are a small group, our pediatric transplant group is pretty small. It's really important that we join together, like what Transplant Families has started. So our overarching theme for this year is hope, health, and strength. I think we all can understand what that means, but just to break it down a little bit, we have monthly or bi-monthly calls in which we try to schedule our hour in which we do something to provide hope. We also talk about health and how to improve the health of our patients, and also to give each other strength. So just this year alone, we had a call in January in which we celebrated the 500th kidney transplant at Children's Hospital of Philadelphia. It's adoringly called CHOP. And we had the clinicians who, Sonia Lopez, who is a transplant coordinator, was there for all 500 transplants, along with Dr. Ben Laskin, who is one of the, I believe he's the chief right now of the transplant clinic at CHOP. To talk about what they've learned over the 500 transplants that have been done. In February, we had Kelly Helm, who is a patient advocate for NephCure, talk about advocating for your child. Just recently, we had the amazing Allie Brock, who is also a kidney transplant recipient as a teenager and is now a transplant coordinator, nurse practitioner, just talking about transition to adulthood, because here's somebody who's walked the walk. It was amazing. Right now, we're in the middle of our Transplant Families Conference, and in May, we were hoping to talk about the cutting edge news of xenotransplantation and hopefully have someone come on and talk to us about that. It's not just all about learning, it's also just checking in with each other, hearing how everyone's doing, highlighting kidneyversaries, and just being there as a support. So some of the projects and educational materials that the CEW has put together are blood pressure materials, educational videos, excuse me. We have a list, and we update it every year, of summer camps and scholarships. And I'm actually in the middle of doing the scholarship list right now, as my one daughter, who has a kidney transplant, is a high school senior and will be going off to college. And we also put some information about kidney shields and protectors, just not that we're endorsing anything, but just from, experience as being caregivers. One of our, I think, one of our best materials that we've developed is rejection materials for both parents, which is what is kidney rejection, and also written something for children, what is kidney rejection. It's a scary word, the rejection idea, and just to have this kind of document that was made by caregivers available in our IROC centers is just an example of something that we do. It is also available in Spanish, and we're very proud of that. Another thing that came out of just an organic discussion and a little bit of frustration about insurance and Medicare is a FAQ that was developed with the help of an amazing woman out of Cincinnati Children's who helped us really navigate Medicare. So this is the first page of a 3-page document that has hyperlinks that you can refer to really help understand what all the ins and outs and the intricacies of insurance. Transition to adult care. This is our most recent project that we just completed. It was started again by parents who just had a lot of questions. Our children are moving into that adult care, and what does that mean? So we we had a subcommittee of the CEW. We met with Got Transition, which is a federal organization about transition to adult care. We had other clinicians help, and we created a user-friendly guide with some hyperlinks in it and just things that you should know, because how do you know what to ask? How do you know how to prepare your child if you've never done it before? So this guide is just that toolkit to help you. And then the other thing we do is we talked about is partnerships. So the CEW is a go-to when the Scientific Registry of Transplant Recipients are looking to update their website and be more user-friendly. They came to us and picked our brains about what we could do to help them. We've done a lot of feedback and completed a lot of surveys for a number of organizations that are on here. We also feel very strongly about advocating and moving forward and advancing what needs to be done in the field of transplantation. So we've partnered with UNOS. American Kidney Fund has been an amazing support. They run an amazing monthly camp for children, and we get that out to our families. This American Society of Pediatric Nephrology has asked us to get the word out, to provide some support for research that's being done and making sure that, we are tapping into our families. Okay, and the last is if you have any questions, and you will also notice the red IROC, because I think that's a great way to remember what IROC is all about. Thank you for listening.